Ladies and gentlemen, thank you for standing by, and welcome to the Quest for Managing Electronic Health Record Compliance in Healthcare webinar. At this time, all lines are in a listen-only mode. Later, we'll have a question and answer session, and instructions will be given at that time. If you need assistance on today's call, please press star, then 0, and an operator will help you offline. As a reminder, today's conference is being recorded. I'd now like to turn the conference over to Senior Vice President, Corporate Responsibility, Michelle Cooper. Please go ahead.
Welcome, everybody. We're pleased to present another educational webcast, this time with regards to electronic health records and all the compliance issues that are associated with that. Before we get started, I would like to offer the following prayer. And this actually is a prayer that is attributed to Sir Francis Drake back in 1577, so a very old prayer, but I think just a really good one. Disturb us, Lord, when we are too well pleased with ourselves, when our dreams have come true because we have dreamed too little, when we arrive safely because we sail too close to the shore. Disturb us, Lord, with the abundance of things we possess. We have lost our thirst for the waters of life, having fallen in love with life. We have ceased to dream of eternity, and in our efforts to build a new earth, we have allowed our vision of the new heaven to dim. Disturb us, Lord, to dare more boldly, to venture on wider seas, where storms will show your mastery, where losing sight of land, we shall find the stars. We ask you to push back the horizons of our hopes and to push into the future in strength, courage, hope, and love. Amen. And with that, I am pleased to introduce everybody to Lori Richter. Lori holds several certifications, and she actually joined CHI in 1999. She's responsible for providing compliance leadership, guidance, and consultation in the development, implementation, and maintenance of CHI's many electronic health record programs. Lori's background includes management of health information management departments prior to joining corporate responsibility in 2011. Lori holds a Master's of Arts in Leadership, a Bachelor of Science in Health Administration, and an Associate in Health Information Management. So, Lori, welcome, and thank you for your presentation today.
Sure, thank you, Michelle. So, as Michelle introduced, I'm the EHR Compliance Director at CHI. This is really a fairly new role within CHI. Probably, I would say 3 years ago or so, I moved into this role. And it's not just a new role at CHI, it's a new role within the industry. Previously to this role, I kind of lived and breathed in healthcare, but in health information management, privacy, and other compliance roles. Those roles, I think, give me the unique insight in this ever-changing and exciting world of electronic health record compliance. There's so many regulatory developments in the healthcare industry today that have really contributed to the boom in health information technology and adoption across our hospitals, clinics, and other healthcare entities. This really created the need for this more defined compliance oversight role in our electronic health records. And I will say as well, I was at a conference earlier this month, and at that conference, I was with a lot of other health information management, revenue cycle, and compliance experts. And I think I met one other person that really holds some of this same type of role, which is providing EHR compliance oversight in healthcare. And it was wonderful to meet and talk to her because, like I said, it is such an emerging world and role that it's so interesting and vast, but unique and new. So today, the objectives for our education, we're going to ensure that participants understand the importance of compliance in EHR environments. We're going to, from now on, instead of saying electronic health record, I'm going to say EHR. We're going to talk about the EHR footprint at CHI and ensure you understand that, as well as the top EHR compliance concerns, and then strategies to mitigate the risk from a fiduciary perspective. So let's begin with the footprint across CHI. Here's a rather large map. I want to first define a term that I think most of you have already heard, and that term is OneCare. So OneCare, I believe it really first came onto our landscape at CHI about 6 or so years ago with the implementation, actually probably a little bit before then with the discussion of what do we want to do at CHI to implement our meaningful use electronic health records. So at CHI, I asked marketing, how do you explain what OneCare is at CHI? And they said, in their words, OneCare is the enterprise-wide CHI program that encompasses all activities and governance related to electronic health records within CHI. The goal of OneCare is to improve patient safety and clinical outcomes through the use of EHRs and standardization of clinical practices. So as you can see on this slide, I've got a key on the bottom left, and that key depicts our 4 largest OneCare electronic health records that we have implemented the last 6 or so years across CHI. We have Epic, which is in our hospital and clinic environment, Cerner, and 2 different types of Meditech, which is also hospital applications. And then we have Allscripts, which is a complement in the markets that use Cerner and Meditech at the hospital. Their clinics use Allscripts. We also have this light blue color that I called Other. That is, I should say, bigger than what Other depicts. But the Other is going to be a conglomerate of, I'll say, in home care, we've got Point Click Care as the new electronic health record over there. We have some specialty electronic health records such as Mosaic, which is in our oncology environment, or a best-of-breed type of electronic health record that we've had in our heart facilities such as Chattanooga Heart, Nebraska Heart, Iowa Heart, which is Next Gen. A majority of what we do have, though, a largest amount of our users, such as 60 or 71,000 users across CHI, utilize Epic every single day. In Epic, you will see kind of that bright orange or salmon color across almost all of our markets, except for over in that Kentucky region right now. Let me give you an example of how complex or convoluted, depending on how you want to say it, our markets can be. So let's focus on Nebraska for a minute. If you look at right there, the dead center of the country, we have got, I think, every single color and then some in Nebraska. If you look on the eastern side of the state, we'll call it the Omaha or Allegiant side of the state, they have Epic. They have Epic for their hospitals and for their ambulatory entities, so their clinics. As soon as you drive east down Interstate 80, outside of Omaha, start heading towards Lincoln, Grand Island, Kearney, Nebraska City, you're going to run into our Meditech facilities, and that's actually Meditech 5X. In those Meditech markets, their clinics are on Allscripts. In addition, you probably noticed that little light blue color, which is the Other, and that Other is Nebraska Heart in Lincoln, Nebraska, has Thorian at their hospital, and they have Next Gen for their outpatient clinics. Let's also not forget about Mosaic that we have in the oncology departments in Grand Island, Kearney, and Lincoln. So I think right there I've named, well, all of them. I think we've got 4 or 5, 6. I think I named different electronic health records just in Nebraska. But let's not forget the 4 patient portals that we also utilize in Nebraska. So Epic has a patient portal. Meditech and Allscripts shares a patient portal, which is amazing. So those patients that go to a Meditech hospital and follow up with their provider that's in an Allscripts clinic, they have the same patient portal. That's wonderful. But let's go into those specialty or best-of-breed situations. So Next Gen in Nebraska Heart, they have their own patient portal. Let's look at Mosaic in our oncology entities, our oncology departments, provider-based departments, mind you. They also have their own patient portal. So here in Nebraska alone, you could be one patient, but have access to 4 different patient portals. That is complex. Is it ideal? No, but it is complex. And let me explain one situation of why you will see that. You know, when we first started implementing those OneCare electronic health records across CHI, there was a plan. There was a roadmap, phased rollouts, etc. But you know, just like any other best laid plans, things change, and you have to move, and you've got to position yourself for changes in the environment. During those implementations, we had an abundance of new acquisitions, including the Omaha market of Allegiant Creighton moved from being a joint venture to being fully owned. When we acquired them, moved them, I should say, to being fully owned, they were already kicking off their Allegiant Epic implementation. We also, at that time, the Meditech market that I mentioned of St. Elizabeth, St. Francis, and Good Sam, so Grand Island, Lincoln, and Kearney, were on a Meditech, an older Meditech system, and they decided to do some pauses and wait to make sure it really made sense, because if the eastern part of the state is on Epic, should we do something else? There's a conundrum of all those different discussions. So all of these various other solutions, even outside of the OneCare, Epic, Cerner, Meditech, etc., as they're sitting there trying to decide, are they next? What phase will they go up onto the new OneCare, Epic, or Cerner, or whatnot? They still wanted to be in line and not lose their meaningful use dollars, and wanting to make sure that they're doing the best they can for their patients. So, for example, in Mosaic and oncology, they needed to implement that patient portal. It's good for their patients, and I will say that patient portal, their patients can do a lot of communication with their providers. They can fill out paperwork prior to coming into the facility. There's a lot of stuff they can do. But yes, is it outside of the other electronic health record patient portals we have in the market? It sure is. There's a couple other nuances that add to the CHI footprint. Because I think what I just explained for Nebraska, I could explain the same type of scenario in Texas, in the Southeast, in the Fargo market, Pacific Northwest, etc. What I would like to mention that is a little bit different in the Fargo market as well as the CHI St. Vincent's area. I've got for that Southeast market, I have a line right there to that, is that we also have what we call an affiliate program, or in those cases, a reverse affiliate program where we have entities, CHI fully owned entities, on somebody else's electronic health record. So that really adds to the complexity and the nuances of how do we really, not only if we don't have accountability over implementation, but how do we respect that other entity's implementation, but ensure that our patient's medical record and legal and compliance risks are looked upon in the vein that we would expect. So up in Minnesota, part of that Fargo market, we have entities on another market, Epic system. Down in St. Vincent market in Hot Springs, we have our market on an Epic system from where we acquired them from. So we have to work through that as well. One other term before I move to the next slide is that we actually, if you count them up and look at the application inventory, we have about 142 separate electronic medical records across CHI, including 10 that have been retired. So that's quite the footprint and makes for quite the, I'll just say, work. So in that conference that I went to earlier this month, I had the opportunity to listen to Newt Gingrich and Barbara Boxer actually do a debate. It was quite interesting. It was during a general session one morning. One thing that I thought was very pertinent for this presentation was a quote that he directly said, which was, healthcare is 10 times more complicated than national security. I personally couldn't agree more. I think at times we, or leaders across healthcare, are what is making it so difficult, truly. I think decisions that were previously made in our paper environment that were done by this multidisciplinary team of billing and coding, clinical leaders, medical records, registration, they're now being decided by IT teams that are not the business owner of the medical records. And we should not put that responsibility on them simply because we move that medical record, that clinical record of our patient's care from the file room that used to be housed and locked up in medical records or health information management to an IT server room or a cloud. That does not mean that IT should now be the gatekeepers and decision makers of that content, of that build of that electronic medical record. But I've also seen concerns across the country, not just CHI, but all over, where IT, information technology, works solely with clinical teams and requesting them to make decisions that they never have before. So clinicians, gosh, they have got so much on their plate. They understand what they need to do for the documentation, what they are expected to evaluate when they're in front of those patients, what they need for patient care and workflow. Huge, huge piece. But we need to ensure proper understanding and input from revenue cycle teams, compliance, patient access, etc., all of that with those clinical teams and IT teams to make sure that we're successful. So being able to speak to those teams together and form a multifunctional team, and I'm going to mention they're calling an information governance team here on out, it's crucial. And there's no other way really to maintain the integrity of those medical records and make sure that they're truly there to document and maintain through the lifespan of that charge for that patient's care and for our business record, that patient's information. Okay. So as I said, we're going to talk about the top EHR compliance concerns. Before I get into concerns and focus on the complexities and concerns of EHRs, I'd like to point out some very good reasons EHRs are extremely good for healthcare and good for our patients, and it is the right thing to do. So when healthcare providers have access to complete and accurate information, patients receive medical care. Receive better medical care, I would like to argue. EHRs can improve the ability to diagnose disease and even reduce and prevent medical errors and improve patient outcomes. I'm going to give you 3 statistics. A national survey of doctors who are ready for meaningful use of their electronic health records, they report evidence of, and here I'm going to give you 3 terms. 94% of providers report that their EHR makes their records readily available as a point of care. So it's at their fingertips. They know what they're doing. They've got the information from yesterday's visit to help them today to clearly see the picture of that patient. 88% reports their EHR produces clinical benefits for the practice, and 75% of providers report that their EHR allows them to deliver better patient care. That's huge. That does mean we're going in the right direction. It means that, you know what, if we can just fix some of these concerns and make sure that everybody's at the table to keep this a clean system, keep it healthy, keep things documented, make sure that they're up when they should be, then I think we're going the right direction. I think the electronic health records can aid in diagnosis, they can help reduce errors, they can improve patient safety, and they can support better patient outcomes. It can make a difference for patients. Here are the big block items that I'm going to touch on. It really talks about what I consider the top electronic health record concerns across CHI, but really across our industry. And it is integrity, interoperability, business continuity, and IT disaster recovery. The electronic health record environment is so much more complex than the paper world, and I know I keep bringing back to in the paper world, but we're going to continue that theme. In the paper world, clinicians wrote down their assessment, their plan, other details about that patient visit as they were sitting in the room with that patient, mind you. Results were routed and placed in the chart. So, maybe we were waiting for that lab result back, but once it came back, it got put in that manila file folder. Orders were written and signed, and the chart was treated truly as sacred documentation. Let's stop and think about this for a minute. In today's environment, poor EHR system design and improper use can cause EHR-related errors. If we have concerns about the integrity of the information, if we don't have the system designed properly so the information can flow to those providers, we could lead to endangerment of patient safety, decrease in the quality of care, and we need to be cautious about that. Policies, usability principles, and best practices for proper electronic health record systems have not been widely and consistently adopted. I will say when we first opened up our Electronic Health Record Compliance Committee and program about 3 years ago. Actually, the committee was 4 years ago, and then we moved into myself in this full-time position 3 years ago. We really looked around at the industry to identify, is there any best practices? What do people, when you're looking at electronic health record, how do you assess it for compliance with revenue cycle needs, with medical record integrity needs? How do we make sure privacy and security and general compliance and all that is taken into account? And we found there wasn't anything out there. We really had to pull together and create our own compliance requirements. And, it goes anything from, our minimum necessary rules taken into account, such as, do people have access to the records that should, but people don't have access to records that they shouldn't have, all the way to is documentation getting onto the record that needs to be there. We as an organization need to take accountability for the integrity of those records, and I think we did by pulling that together. We need to ensure that design is what meets our needs, our requirements, our workflows. We also need to understand that vendors are not held accountable to the build and the effects that they may have on our documentation and patient care. We, as a healthcare entity, are. Back in the day, back in 2003, when I was a privacy officer and living and breathing more in that environment, I remember when we would have a vendor come in, one of the first questions we would ask is, are you HIPAA compliant? And, of course, the vendor would say, yeah. Well, what I've learned since then is, they can say that, but it's really how you implement it. And the vendor will say, well, we told you we're HIPAA compliant, but then we asked you if you wanted to turn over those audit logs. You said no. But by us choosing to not turn on an audit log, that is making us not HIPAA compliant. So they're true. They've got the ability to be HIPAA compliant, but if we don't turn on the audit logs, then we're not HIPAA compliant. So that's just kind of a nuance there. I'd like to take a step just to kind of explain integrity in an analogy. So data and information are fluid across healthcare organizations as the water is in our physical ecosystem. Think about the water pipes in an organization. You can go to the restroom and wash your hands. You can go to a drinking fountain or the cafeteria to get a drink of water. Wherever you go to turn on or use your water, you know that the water is coming out clean. You can trust it, or at least you hope you can trust it, and you know it's coming from a reliable source of water. On the flip side, it's hard to say the same for our data and information that flows through the organization. Can we trust it? Can we access data and information and know it's coming from a trustworthy or reliable source? The problem is I don't know. I mean, at times when I'm looking through assessments, when I'm talking to these vendors, when I am finding an error in our EPIC system, it really makes me question the intelligence of our information. With all this information, we need to ensure that we can depend on it. We all share it. We're all custodians of it. We all use, this just like we use the water in our communities, and everybody has a responsibility to keep it clean and consumable. In this analogy, the IT governance. So when I mentioned the term IT governance, I was talking about that multidisciplinary team made up of clinical teams, revenue cycle teams, IT, business intelligence. That really represents the tanks, the water tanks, the valves, the pipes. Information is the water flowing through these pipes. Governance of information requires governance of the technology to ensure we have a clean healthcare ecosystem. We should never forget our purpose of clean documentation. As a reminder, and just to make sure everybody understands what our goal is with these electronic health records, is no different than it was in the paper world. Our legal health records serve to support decisions made in patient care. Third-party payers document the services provided as we sit there and provide legal testimony about a patient's illness or injury, why we did or didn't respond to treatment, caregiver decisions, and it serves as the organization's business and legal records. I'm going to read this statement for a second as we still talk about integrity. That there are identified blurred lines of responsibility as decisions are made about documentation for clinical workflow and revenue cycle. These decisions are sometimes led by vendors and IT teams who may not understand the regulatory implications of such decisions. So let me give you an early example of a small yet significant issue that occurred early on at CHI in our implementation. It's such a simple, small thing. And it's about signature line integrity. I got a phone call one day, and it was from somebody who had just taken a look at some documentation in one of our oncology departments. The question was, what do we expect on a document when we're printing it out to show us who wrote that document? What a, odd question, right? And I went, well, what do you mean? What do I expect on a document when you print it out? It needs to have, a header, a footer, kind of going through all this stuff. And they're like, well, no, how do you expect, if you've got all this documentation and then you've got a signature line, what needs to be on that signature line from the provider that did the documentation? I said, well, the full legal name of the provider, their credentials, so MD, DO, PA, ARNP, whatever, and the date and time. So full legal name, date and time. What I heard on the other end of the line was, no, that's not what we're seeing. What I'm seeing, I printed out this document, and I see a signature line, but it's really tiny, and it just has the initials of the provider. So instead of Rob Stevenson, PA, it says RS, PA. I said, no. Let's look at this. So, as I worked with the oncology team, worked with the application group, and the I'll call them system administrators within the department that set up the documentation, they were doing what they thought was right. They were creating the documentation output to save room on the paper, to make it so that they weren't printing out extra pieces of paper, and really trying to make it succinct. Little did they know that there is legal requirements to have the full legal name and authority, so MD, DO, etc., and the date and time for the documentation to be legal, accurate, complete. It's part of record integrity requirements. Very interesting. I'll say it's very dangerous to have team members building screens or working with a vendor on suggestions who do not understand what the output of this legal documentation needs to be. You know, like I said, and it's not just the full clinical name. We need some headers and footers that identify the CHI facility name and all this other stuff that you guys don't need to know about, but you need to know we're taking care of it. So one small example here would be the output in one of our EHRs as well was not set up to include pathology reports. So let's think about that one. You know, one day I also got a phone call that said, hey, Lori, we sent records for a subpoena. There's a legal case going on, and the attorney just called back and said there's no pathology report. And I said, okay, so why does the attorney know that there should have been a pathology report? That's an odd thing, you know, for them to call and say, where's the pathology report? And they said, well, it was an oncology surgery case, and they had taken out a specimen. So, yeah, there should be a pathology report. And they said when we looked in the system, there was a pathology report. And I said, okay, so why didn't it get sent with a subpoena? And the answer was, because we didn't set it to print as part of the legal medical record. The team that chose what the output would be didn't realize the pathology report is part of the legal chart. Wowzers. I'll just say that is a huge mistake. And you know, just like I wouldn't question a physician when they, you know, with a lot of their clinical determination and their background and their knowledge, and I wouldn't question IT when they're programming something, we need to make sure that we've got the right medical records, governance, integrity type of team members in there to manage that legal documentation. So that's one example for you. Let me say this too. Imagine, as a board member, you were told the entity has to pay back money, possibly tens of thousands of dollars to Medicare because your medical record documentation did not support properly medical necessity for the services rendered. Think about that. Noodle on that while I talk about the next scenario. This is a real life scenario as well. So I want to talk about protocol orders. Centers for Medicare and Medicaid Services requires physician's signature for protocol or standing orders. Specifically, and I'm going to read this from the reg, says specifically outlines several requirements for the use of pre-printed and electronic standing orders, order sets, and protocols, one of which is that they ensure that such orders and protocols are dated, timed, and authenticated promptly in the patient's medical record by the ordering practitioner or by another practitioner responsible for the care of the patient. Okay, let me explain this. So in the paper world, we had pre-printed standing protocols. So maybe it's a mommy that comes in to deliver a baby. The nurse knows that there's possibly already a chart started for that mommy because the doctor knows Lori's going to go to St. Elizabeth or wherever that is to have the baby, and he said as soon as she arrives, start this protocol. Okay, so the protocol might need to start the saline, check if she's dilated, you know, all these different things that, you know, go along with a normal newborn delivery. In the paper world, the nurse would already have that on the chart because the physician, you know, says, yes, whenever my normal newborn moms show up, I want this initiated. Well, when he would come in my case, Dr. Tom Jack would come in, he would then go to that paper chart and he would have signed off on that order going, yep, you started that. But it was within the nurse's scope of practice to initiate that before the doctor arrives. And another example is that nurse called that physician and said, you know what, Lori's really not progressing. What do you suggest? And let's say he says, you know what, let's just initiate some Pitocin. Okay. So that nurse then goes and writes that order, her protocol or verbal order, Dr. Tomjak in the chart. You probably can't see me, but I'm pretending to write on a piece of paper because I use my hands to talk. So, as you know, she's writing down that order. It's like, okay. So then when he comes in later to hopefully deliver that baby healthy, he will sign that chart, sign off on that protocol. So yes, the nurse put it in. It's within her scope of practice to listen to him, repeat it back to him, put it in that chart. But they also need to sign off on that order. So when he comes in, he would sign off on it. Let's say by chance he didn't get that chart in front of him or he missed that one page of the chart and didn't get it signed off on. After discharge, Later, in the paper world, he would have came to the physician lounge where we would have given him that chart. The medical records team would have given him all his charts, but he had anything to finish, signatures to finish, a dictation to finish, and he would finish that. Now let's fast forward to today's world. That nurse puts in that protocol electronically. What that protocol order should do is it should go to that physician's work queue, task list, there's all kinds of words for these, for him to sign off on electronically. Easy peasy, not a problem. Electronic signature, vetted, done. Well, in more than one of our systems, it was not set up, in all cases, for protocol orders to route to a physician. Luckily, in most cases, it was found very early on in implementation, and then what we end up doing is dividing a project between fixing the here forward and a reactive fix for the backlog. I'll say there's always twofold there of, okay, how do we make sure and fully evaluate what did it affect, what didn't route to those physicians and why, and there's always so many nuances as to the why. And then how do we, fix that here forward so it does not happen again, and then how do we fix that backlog and get, let's say it's, 20 signatures that Dr. Tom got to finish that he wouldn't have done if we didn't pull them out, print them, and possibly get them to him. So we could be out of compliance not only with CMS, but also with conditions of participation. So once again, let's think of that scenario. As a board member, you're told the entity has to pay back money, possibly tens of thousands of dollars to Medicare because your medical record documentation did not properly support medical necessity for the services rendered. That could mean exactly what I said. That could mean the workflow didn't initiate, it didn't go to that physician to sign off on. And there's nowhere else in the chart that you can understand that was his desire. We can't find the accountability. We truly need to understand how did it happen. Okay. So let's stay with integrity. So let's look at another quote. And this is from Dr. Charles Joffe. He's the CEO of Health Level 7 International. He said, medical errors are the third leading cause of death in the United States, leading at 400,000 per year. In my eyes, that is astronomical and not necessary. In an article that I read on Politico.com, the author wrote about an elderly woman who had stabbed herself with a garden fork. No, this wasn't at one of our facilities, at least not that I'm aware of. An emergency room nurse clicked in their EMR a phrase that said unknown / last 5 years for the woman's status as to whether or not she had a tetanus shot. A doctor took this to mean that she did not need a tetanus shot when in fact she had never received one. Guess what? That woman ended up dying of tetanus. Wow. Talk about a misinterpretation of unknown last 5 years. In another case, which ended up settling for $10 million, the plaintiff maintained that an error in his medical record led to the use of an inappropriate antibiotic that caused him to require dialysis for the rest of his life. Just makes you sad. So there are two categories that I believe all EHR errors can be defined down to, and it's unsafe technology and unsafe use of the technology. Unsafe technology, in my eyes, refers to glitches in the system that are beyond the control of the user. Unsafe use can be tracked back to insufficient training or simply human error. Think of I don't even want to admit this, but driving yesterday in my son's basketball practice and going down the road, and I'm looking at my GPS, which should be fine, but it's telling me where to go. It's somewhere we've never gone to before for a basketball game. And I'm just not trusting it. I'm not trusting the technology. I don't think the instructions are right. So as I'm looking at it and deciding to re-put in the address, guess what? I went directly through a red light. I'll say my heart dropped, both kids in the car, and I hear them go, Mom, it's a red light. Thank God it was not a busy area. There was nobody coming. But I will say that was unsafe use of my technology, of my GPS. That was also unsafe use of the technology by myself. And then what I went beyond to explain to my children was how important it is to not be distracted when you're driving, and also how important it is to make sure that you are using defensive driving, because you never know when there's somebody else making that stupid mistake like I did. Okay. And I'm hearing some muffling on the phone. I don't know if there's somebody that needs to go on mute. Okay. And let me go to the next slide here. This one's interesting, and it takes us to our next conundrum. So I think I mean my three compliance risks. One was integrity, and the second is interoperability. So let's talk about interoperability. This is a quote from Dr. Don Rucker, the National Coordinator for Health IT, or Health Information Technology. At that conference that I will say was amazing a couple weeks ago, he said, "We don't have the best interfaces. We have a lot of government policies that as we implement them, they cause problems for us." He went on to explain two focus areas where we, healthcare IT, healthcare industry in general, need to do more work. And it's the usability of the provider burden and interoperability. We have so much information sitting in silos. These problems can also be called conflicts. We have requirements for interoperability, but we also have privacy regulations which require entities to ensure we only share information that providers need to know or have a legitimate right to do. I'm sure everybody on the phone has read numerous healthcare articles, IT articles, stuff from the government, stuff from vendors that talk about, oh my gosh, this new whiz-bang widget can allow us to share information smoothly, quickly, fast. We need to open it up. We need to make sure we're sharing. There's a problem with that. Yes, we need to share information. And you know what HIPAA has said since 2003 is we can share information for treatment, for payment, for healthcare operations without an authorization. We should be sharing that. When I was a privacy officer, I used to have to defend that HIPAA was not bad. HIPAA was a very good thing. It opened up our medical records to share it more smoothly with those that need it. But it also closed it better, added additional requirements to make sure that those that shouldn't have access to it don't. It really talks about role-based access, minimum necessary, all these other buzzwords we've heard for 14 years now. That has not changed. HIPAA did not go bye-bye as soon as we implemented our electronic health records. And Dr. Don Rucker, from our National Coordinator of Health IT, works directly for the government. He agreed and said, yes, we agree. We need to open up information. We need to share more freely. But he said that doesn't mean privacy goes out the door. Does not mean that. He said privacy is first and foremost important. We need to make sure that as we're sharing with our other providers, with payers, with patients, that we make sure that that information is properly segregated and that we're sharing only what that person, that requester on the other end, is properly legally allowed to have. That is really tough. And by really tough, let me get into our next scenario, and let me do a time check for myself here. At 10 after, okay, I think I'm good. Okay. So interoperability. Let's talk about divestitures and transfer of records. Really what I generally call this, and I've spent lots of hours on this lately, it's really exit strategies. So it's those scenarios when you have a provider or two or three, or an entire clinic or other healthcare facility that's choosing to leave, or we are choosing to divest out of our CHI landscape. So in the past, when a provider or a clinic was choosing to leave, it was pretty straightforward. Our legal team would work on the exit strategy, the divestiture, transfer of records, contracting. Those transfer of records, documentation, it was pretty clear on who kept what assets. Let's pretend it was very cut and dry. So back in the day where we still had complete paper records, if we were choosing to sell a clinic to a new owner, and they were going to take over the clinic that used to be ours, that contract would speak very clearly to the fact of what assets are we, giving them. You're not giving them, but are they contracting to purchase, the desks and the equipment and all that good stuff. But in addition, it talks about the files and the patient medical records and Are they taking over ownership and responsibility for record retention, disclosures, requests for information, all of that, or are they staying with the CHI, entity? In the electronic world, what we're having to discuss and talk about is updating those contracts, and also I'll just say, not just updating of the contracts and understanding the ownership of the medical records, but we have to talk about how do we do that. In the prior world, if we were shutting down a clinic or transferring ownership to another entity of that clinic, they could literally, we could shut off lights today and they could turn them on the next day, in reality. And, they could walk in, the file room could be theirs if properly contracted. In the electronic health record world, it's not quite so simple. You have got I'll say in most markets, and let me explain, like in our all-scripts markets, they are set up that the region, if all under CHI, they all share one large medical record. So it used to be the ENT office, ear, nose, and throat, would have their own chart. The family practice office would have their own chart. The OB office, the pediatrician's office, etc. In the electronic health care or health record world, they're all sharing one large electronic medical record in their market. So in Nebraska, let's pretend it's 30 clinics. The 30 clinics that have Allscripts, they're all sharing their Allscripts medical record. If one of those clinics chooses to leave, we can't just hand somebody the record if they contracted to maintain ownership of that chart, there's all these other things we have to think about. So what do we have to do? Well, my gosh, not only do we have to worry about record ownership, we also have to worry about continuum of care. So let's say that no, we're not, that clinic, actually we're closing it down and these 3 providers, they're going to go over to a different entity across town. Well, would we, in the paper world, would we have even given those providers their charts to take with them? No. It's not the provider's chart. It's really the patient's medical record that we're retaining, according to law, on their behalf through the record retention, and we have it available to disclose according to requests from the patient, attorneys, other healthcare providers, etc. Okay. So let's say we choose to keep the chart. How do we deal with it if the providers then say, well, we still want it because all of our patients are going to leave with us? Okay. So let's think about a couple other laws here. How do we make sure that we know those patients are leaving with Dr. Smith, Dr. Johnson, etc.? Well, we have to work out very clear transfer of record processes, such as for continuum of care. If we know that, yes, that patient, we validated that patient is for sure going to leave and go with Dr. Johnson to his next clinic, we absolutely can provide documentation for continuum of care. But what if we don't know that? We will probably work with authorizations, etc. But let's jump ahead. Let's pretend like that's all figured out. How do we transfer that information when we really have it integrated into one electronic medical record? So like I said, in the paper world, your ENT office, so the ear, nose, and throat office had their own paper file. Your family practice had its own paper file. In today's world, they're all sharing one large electronic health record. What we're learning and what we're spending time with our vendors trying to decipher is how can we export electronically that medical record so that if we deem appropriate, it can go with that provider to his new clinic. That is hard. It can be expensive. And I don't think it happens the way that people expect. In the world, hopefully I'm going to say hopefully in 5 years, we've got this interoperability stuff figured out better. But there are no legal requirements for my medical record in Nebraska to look like your medical record in Iowa to look like somebody else's in Tacoma. Every medical record and medical record system is set up different. And it isn't a 1-to-1 ratio. So we can't electronically transfer or I'll say Jane Doe's medical records from our system to the place where she's choosing to transfer her care to. Sure, there is different requirements within meaningful use, for example, called direct messaging, where we can send, I'll call it a summary document. You might have heard of a CCDA to that other office. It's a great document. It shows medications, allergies, problems, their last visit, some of those very pertinent information. But if that provider is contracting to maintain the full legal medical record, that's not one document. So what we're having to work through is how do we do that? Well, we can actually dump patient's medical records, and I won't get into the nitty-gritty, but into a file, and then have this secure file location where this other entity that contracted for can grab it out of and put it into their system. I put it into their system. It's not as smooth as it sounds. It's actually one file per patient, and then almost like one PDF with multiple pages. So I'll just say it's kind of sad, truthfully, that our operability and interoperability isn't there in healthcare. There is a question that as a board member you could ask, and that question is, ask your team, as providers leave their entity or leave or divest your clinics or your hospitals, if they're ensuring proper contracting and validation of rights to the medical records being transferred with updated contracts to ensure they can take into account the electronic records. It's not simply a file room anymore. That was probably a little wordy. I guess the question really is, hey, what are you guys doing when physicians leave now? Have you thought about the contracting process? What has changed? How do we get those electronic records now to the providers when they leave, if they need them for continuum of care or if they're taking over ownership? Okay. So this is our third big block, which is business continuity and IT disaster recovery. I'm going to kind of do this backwards, and I'm going to read what's on the screen first. It says the reality. Employees, physicians, and patients lose respect for and faith in the care of the organization providers. Let me start over. Employees, physicians, and patients lose respect for and faith in the care the organization provides to them. Credibility is easy to lose and hard to earn. Well, let me do a very quick time check. Can I ask really quick, Amy or Ryan, do I have 10 minutes or do I have...
Lori, this is Michelle. You have about 12 more minutes.
Okay, thank you. Okay, so let me just give one scenario instead of the multiple that I had. Let me just say, imagine as a patient that you're sitting in a clinic waiting room, you're stressed, you're in pain, you overhear the provider telling the front staff that the EHR is down. Let me jump to the next one. Imagine as a provider, a patient presents in your clinic and states they were in the ER 2 days ago with stomach pain and the pain has come back. You try to review your records to obtain the results from labs and documentation from the ER, but the information isn't available. At CHI, we have had these occurrences occur before. We have had network vulnerabilities, loss of backup systems, backup solutions. When those occur, I will say we have to pull together very quickly that multidisciplinary information governance type of team to look at what do we have, how can we recreate records. We have to work with our legal team, with our marketing team to say, hey, when we have a subpoena and we don't have information available, how do we explain that we've had a technical failure? And at what point, how much effort can we put into data recovery? There's one data recovery issue we put in over 2 years for. And I will say that was because we had 160 million documents inaccessible due to a hardware failure. 160 million documents, that would be a scanned copy of a radiology report, a history and physical and progress note, etc. Thankfully, we got down to only 1.2 million lost, but we still have to evaluate that. That was my time creeping away. Let me jump to this slide, and you may have seen this before. This was worth repeating. It was from the privacy and security presentation from last fall. It really talks about business continuity. We've got so many opportunities and challenges and mitigation efforts that we need to undertake here at CHI when it comes to business continuity. We need to develop best practices. We need to move from a reactive to a proactive approach. And I think what I've seen at CHI when it comes to our data recovery and our backup solutions is that, it's kind of like at home and the conversation I have with my husband about how much life insurance should we have. What do we need if something happens to me or my husband, Corey? It's like, well, how much can you afford versus how much can't you afford? And I think that comes down to business continuity as well. In addition, I think, a lot of times when we are moving out of maintaining the servers at CHI on our own, because honestly, we're just not doing it that well, and sometimes our vendors can do it better. But as we move some of our servers and our backup responsibilities to our vendors, We're releasing that control or operational responsibility to a cloud provider, moving from having it on-premise, so on-site at our CHI site to the cloud. We need to ensure that our agreements are properly written so that vendors understand their responsibility and that we understand and trust their level of security and proper implementation of their security controls. We need to ensure our IT security addendums are in place. And if this is done properly, breaches would be the responsibility of the vendor, although, keep in mind, when the media releases a news story about data loss, they would most likely say, CHI loses patient data breach. We're the ones that will lose that public confidence. The tagline might mention the cloud vendor, but in the community's eyes, they entrusted us as their healthcare entity of choice to protect their information. Let me talk about risk mitigation and board responsibilities to wrap up the presentation for today. At CHI, we have myself, and I have one team member, but I also have a multidisciplinary committee that I work with that helps provide oversight and identification of potential compliance issues across CHI. I consider those assets, those multidisciplinary team members from, various revenue cycle teams, other compliance team members, clinical team members, our CNIO, our Chief Nursing Informatics Officer, I work with her closely, obviously legal and risk at times as well, but we work together to really provide identification and review of compliance risks when it comes to electronic health records. We really look at these concerns like the ones we've mentioned today, and we put them into, I'll call my risk assessment framework, where we have proactively integrated some necessary controls or business requirements and standards into new application installs, merging with new entities. When we get a new entity into CHI, we look to see what do they have for an electronic health record, and is there any issues that we've noticed with that EHR before that we need to look at, that we need to incorporate some compliance into, maybe make some recommendations for mitigation or changing. So we've got those compliance standards. We've got business requirements. It's really a great multidisciplinary group. From a governing board responsibility standpoint, let's pull it all together and let's outline, really in response to EHR risks at our organizations, what do we need you all to be knowledgeable about? What will help you guide our organization into the next century, really? And it is to be knowledgeable of significant changes in regulations related to electronic health records in the landscapes in our CHI environment. We're made aware of those top risks. So today I talked about interoperability, integrity, business continuity, those risks that are facing healthcare organizations, and query your management. Feel comfortable about that. Ask them how compliance is integrated into EHR integrity. 2 ways to accomplish it, like I said, to be becoming familiar with your organization's IT business continuity and disaster recovery readiness, but also receiving periodic updates on progress and risk mitigation efforts being managed by IT governance teams as applicable to the integrity of a medical record EHR system. Don't be afraid to ask the questions, and always give them my name if they have any, if they don't know how to answer that, say, you know what, you might want to talk to Lori Richter, you might want to, talk to your compliance team in the market. I bet they could help. Let me see, and Michelle, I don't know if you have anything you want to add, or if we should have Ryan see if there's any questions.
Let's open up for questions and see if anybody has anything they'd like to add.
Okay.
Ryan, are you there?
I'm talking with my mute button on. There we go.
There we go.
All right, ladies and gentlemen, if you do wish to ask a question, please press star then 1 at this time. And I'm allowing a few moments for people to queue up. Once again, it is star 1.
Sure.
And it looks like we do not have any questions in queue.
Okay, well, I'll just talk for a couple minutes and we'll check again to see if anybody has any questions. I want to thank Lori for presenting today. One of the reasons why we chose this topic is we wanted you as board and committee members to really understand how complex electronic health records are. They are definitely, the wave of the future, and CHI is headed towards more centralization, having fewer systems, but it's a long journey, a long path, and it's very complicated. And so we wanted to provide you this webinar just to give you an idea of the complexities that are out there, help you with identifying some important questions that you can ask in your oversight roles over electronic health records. I know many of you periodically receive updates from your compliance officer, and they'll provide updates on privacy and security and some of the areas that impact electronic health records. But I think we're going to see more and more compliance issues come up in this arena just due to the complexity. So again, we'll just ask, are any questions? If not, we'll close for the day. Ryan, anybody in queue?
We do not have any questions in queue.
Okay, well, thank you.